Hello, my name is Graeme Meintjes. I'm an infectious diseases physician based at the University of Cape Town in South Africa. And this time I'm going to be speaking on integrase inhibitor use in TB co-infection. So just to start out with some epidemiology, I think it'll be well known to all of you that TB is probably the most important cause of morbidity and mortality among people living with HIV worldwide. It's estimated by the WHO that in 2018, 860,000 cases of TB occurred among people living with HIV. That's about 8% of the global numbers of TB that occurred that year. And while the TB deaths have decreased over the last 2 decades, largely due to the rollout of antiretroviral therapy, it's still estimated that 250,000 people died with HIV associated in the year 2018. So HIV-TB is the most important cause of morbidity and mortality among people living with HIV worldwide. In the talk today, I'm going to cover 3 issues and how integrase inhibitor use relates to them in the treatment of HIV-associated TB. So firstly, dealing with treatment of drug-susceptible TB, and briefly some issues about the treatment of drug-resistant TB, and finally some issues related to TB preventive therapy. So to start out with, we know from several trials that have been done in patients with HIV-associated TB that we save lives by starting antiretroviral therapy during TB treatment, and particularly in those patients with low CD4 counts, a CD4 count of less than 50, we need to start antiretroviral therapy within the first 2 weeks of TB treatment to reduce mortality. In patients with higher CD4 counts, the WHO advises that one can wait until 8 weeks. And this essentially means that we have to confront the challenges of combining treatment for TB and HIV in patients with HIV-associated TB. So if patients are HIV positive, they're diagnosed with TB, we start them on their TB treatment, and we need to start antiretroviral within the first 2 months of them starting their TB treatment. And there are a number of challenges that we need to face in combining treatment for HIV and TB. And that's really, just to go back to the to say that the challenges that we face are drug interactions, TB iris, and drug toxicities. And I'm going to be discussing those challenges in the talk and how integrase inhibitors relate to them. With respect to drug interactions, rifampicin is the main culprit. It's a potent inducer of enzymes and drug transporters, and it does this by binding to the pregnain X receptor and leading to increased transcription of genes that code for proteins in enzymes involved in drug metabolism or drug transport. And with respect to retrovirals, the important enzymes in terms of phase 1 metabolizing enzymes are CYP3A4, which metabolizes many of the antiretroviral drugs. Phase 2 metabolizing enzymes like uridine, diphosphate glucuronyl transferase that was involved in glucuronidation of the integrase inhibitors. And then it also increases the transcription of certain drug efflux transporters like P-glycine that are responsible for pumping drugs across epithelial membranes and leading to drug efflux. And the implications of this are that rifampicin can reduce the plasma exposure to many classes of drugs, TAF, NNRTIs, integrase inhibitors, PIs, and some of the new drugs. So just looking at one particular example, Dolutegravir, what is the effect of rifampicin? Rifampicin induces the enzymes involved in metabolizing dolutegravir. The main enzyme is this UGT1A1 involved in glucuronidation. But it also, a minor enzyme involved in dolutegravir metabolism is CYP3A4. Both of those enzymes, as well as drug transporters involved in the efflux of dolutegravir across epithelial membranes. So the net effect is that rifampicin has an important impact on the exposure to dolutegravir. It reduces the area under the curve by 56%, the maximal concentration by 35%, and the trough concentration with a 24-hour dose by 85%. So very important impacts of dolutegravir of rifampicin on dolutegravir exposure. Now, this has been studied in several studies, and the question has been, how do you overcome this important impact of rifampicin on dolutegravir, such that one might still be able to prescribe dolutegravir in patients being treated for HIV-TB. And this was a healthy volunteer study where patients were dosed with 3 different regimens, either dolutegravir 50 milligrams BD on its own, and that's the top curves, or the ones that I've highlighted are dolutegravir 50 milligrams daily, which is obviously the standard dose, or dolutegravir 50 milligrams BD combined with rifampicin. And what this shows you is that if you increase the dose of dolutegravir to 50 milligrams BD when it's combined with rifampicin, that overcomes the inducing effect of rifampicin, such that the area under the curve is the cumulative exposure to dolutegravir is increased by about 30%, and the trough concentrations are not lowered. And this means that this study resulted in what the package insert advises, that if dolutegravir is used with rifampicin, you increase the dose to 50 milligrams twice daily. This was also studied in patients being treated. HIV-positive patients who were diagnosed with TB were enrolled in the study, and then they were all ART naive. They started antiretroviral therapy. And in this phase 2 study, what was compared was patients were started on an efavirenz regimen in green, or in blue on a dolutegravir regimen, but using the increased dolutegravir dose of 50 milligrams BD. And that was used until 2 weeks after completion of TB treatment. And the reason for continuing for 2 weeks after completion of TB treatment is the rifampicin induction. The effect on transcription takes up to 2 weeks to wane, and therefore one needs to account for that induction that occurs for 1 or 2 weeks after completing TB treatment by continuing that increased dose for those 2 weeks. So what this study, this phase 2 study was not, it was a study of 113 patients. It was not powered to detect a statistically significant difference. It was designed to just compare without a statistical comparison. What you can see is that 82% of patients in the efavirenz arm were suppressed to a viral load of less than 50 at 1 year, compared to 75% in the dolutegravir arm. Now that is a small difference, but when you look at the right-hand table, you see that the majority of failures in the dolutegravir arm were patients who stopped antiretroviral therapy for reasons other than intolerance or virological failure. And when the investigators looked at the drug exposure on the dolutegravir BD regimen with rifampicin, the drug exposures were very similar in terms of trough concentrations while patients were on the rifampicin dose, compared to when the PK was repeated after they had completed their TB treatment and were back on the 50 milligrams daily dose. So this provides further support for using a dolutegravir dose of 50 milligrams twice daily in patients on TB treatment. Now, the question has been asked, is it necessary to actually increase the dose of dolutegravir? Although that's what's advised, and the 2 previous studies that I showed you showed that it helps to overcome the rifampicin induction. We know that that dolutegravir is a very potent antiretroviral agent, and we probably dose it to achieve concentrations that are well above what's required for inhibition of viral replication. And in this study of 14 healthy volunteers, one of the things that they looked at was what was the effect of rifampicin on dolutegravir 50 milligrams daily. And as I've shown you previously, the AUC, the Cmax, and the trough concentration were all significantly reduced. But if one looked at what the actual concentrations were of dolutegravir at 24 hours at the trough concentration when combined with rifampicin. The median was 140 nanograms per mil with a range of 73 to 426. So that what it's saying is that all patients in that study, when taking a dose with rifampicin, actually achieved trough concentration was still above the protein-adjusted IC90 of dolutegravir, suggesting that you may still get efficacy even if you don't increase the dose. And this was an interesting study from Botswana, a retrospective study looking at programmatic data, where they looked at patients who had received dolutegravir while on TB treatment. And some of those patients, 322 of them, actually received a daily dose rather than what is advised, the twice daily dosing. And then on the right-hand side, they looked at the likelihood of viral suppression in those patients who were dosed with a daily dose or with a twice daily dose. And you see with a daily dose, 92% of patients still achieved viral suppression compared to 90% in dosing. So suggesting, and obviously there might be limitations to this data because it's a retrospective study, that we might not need to increase the dose of dolutegravir while on rifampicin because it's such a potent drug, and patients in this observational study still achieved suppression in over 90% of patients with standard dosing. But I'm not suggesting that we advise that at this stage. We need a good prospective clinical trial to show us that we can dose dolutegravir at standard doses with rifampicin. And this is a study that I'm involved in Cape Town, the Radiant TB trial, that is looking at this question in patients who, it's a phase 2 study with 108 participants, in patients diagnosed with TB, ART naive, are being started on tenofovir 3-TC and dolutegravir without BD dosing or with BD dosing. And we are comparing the virological suppression at 24 weeks. So until we have data from this and other studies, advice is when you're using dolutegravir with rifampicin to dose twice daily, but it is being studied as to whether it would be possible to use the standard dose. But as I say, we wouldn't advise that until we have this data available. To move on to raltegravir. Raltegravir, when you combine it with rifampicin also significantly reduces the levels of raltegravir. And the advice in the package insert is to increase the raltegravir dose from 400 milligrams twice daily, the standard dose, to 800 milligrams twice daily when used with TB treatment. This study, the REFLATE TB study, was led by Beatrice Grinstein, looked at whether one did indeed need to increase the dose of raltegravir. So what they looked at was ARV regimens with raltegravir 400 milligrams twice daily, 800 milligrams twice daily versus efavirenz. It was a phase 2 study, not powered for a statistical comparison. But what you can see is that with raltegravir at standard dose with TB treatment, the majority of patients achieved a viral load less than 50 and was comparable to those who increased the dose of raltegravir. So this seemed promising that you could use standard dose raltegravir with TB treatment. However, the phase 3 study, the REFLATE TB2, which was a phase 3 study, was adequately powered for comparison. And here they looked at the raltegravir standard dose, 400 milligrams twice daily, compared it to efavirenz in 460 patients. And what you can see here is that it was a non-inferiority study, and the non-inferiority criteria with the 12% margin was not met in the study. The raltegravir suppression at 1 year was 61% compared to 66% with efavirenz, with the difference -5 and the lower bound of the confidence interval at more than -12 at -13.9%. So while there had been similar virological suppression at 6 months at the end of TB treatment, there was not non-inferior suppression at 1 year, and therefore we can data advise standard raltegravir with TB treatment. Then to move on to bictegravir. Bictegravir has been studied with rifampicin in a healthy volunteer study. Rifampicin has very dramatic effects on bictegravir exposure. And in this study, what they asked was, if you increase the dose of bictegravir from 50 milligrams daily, which is the standard dose, to 50 milligrams twice daily with rifampicin, do you overcome the rifampicin induction like we saw with dolutegravir? And the answer is no. The trough concentrations of bictegravir were 80% lower with rifampicin, even if you dosed it at 50 milligrams at twice daily, when you compared it to 50 milligrams daily without rifampicin. And the current advice is therefore not to use bictegravir with any rifamycin drug based on this PK data and other PK data. So in summary, this slide summarizes the implications of drug interactions when using them with rifampicin, with the integrase inhibitors with rifampicin. Dolutegravir can be used with rifampicin, but we need to increase the dose to 50 milligrams twice daily, as we are investigating other strategies, but until there's data from those studies, that's what the recommendation is, until 2 weeks after stopping TB treatment. Dolutegravir similarly needs to be increased from 400 milligrams twice daily to 800 milligrams twice daily, while in rifampicin to 2 weeks after stopping. And the other integrase inhibitors should not be used with rifampicin. So to move on to one of the major complications of co-treatment of HIV and TB, and that is TB iris. So this occurs in patients who are HIV positive, they're diagnosed with TB, they start their TB treatment, and then they start their antiretrovirals. They're typically improving on TB treatment. When they start antiretrovirals, they have a clinical deterioration. And these are some of the common manifestations. Can lead to enlargement, inflammatory enlargement of lymph nodes that often suppurate, and can lead to recurrence of TB symptoms with worsening of pulmonary infiltrates, as shown in these pictures. So in terms of some summary data on TB iris, occurs on average in 18% of patients with HIV-TB starting antiretroviral therapy. It's been up to 50%. Its onset is typically 2 weeks after starting antiretroviral therapy. And when the central nervous system is involved, it can be fatal. We've done studies in South Africa. Prednisone is the treatment and prevention of TB iris. Just to briefly show you this slide, which was the PREDAR trial, showing that in patients who are at higher risk of a TB iris starting antiretroviral therapy, putting them on prophylactic prednisone for the first 4 weeks of antiretroviral therapy reduced the risk of TB iris by 30%. So what about integrase inhibitors and the risk of TB iris? We know that integrase inhibitors result in more rapid decrease in viral load and a more rapid increase in rapid decrease in viral load, rapid rise in CD4 count are risk factors for TB iris in some but not all studies. Observational studies largely done in Europe showed that, and these were retrospective studies with folder reviews, showed that there was an increased risk of iris, all causes of iris, not specifically TB iris, patients on integrase inhibitors compared to other classes of drugs. However, when one looks at trials in TB patients, patients with HIV, where they've compared patients on integrase inhibitor-containing regimens compared to those on regimens that do not contain an integrase inhibitor, like the REALITY trial, the REFLATE TB trial, and the REFLATE TB2 trial, and the INSPIRING trial, you can see quite clearly that there was no increase in the risk of TB iris in those on integrase inhibitors compared to the control arm. One caveat of this data is that there were very few patients in these studies who had CD4 counts of less than 50. And those are patients at the highest risk of TB iris. And I think we need more data in this population group to definitively say that integrase inhibitors are not a cause of increased risk of TB iris. But I think that the risk of TB iris is not a reason to avoid integrase inhibitors. We do not have data at this stage to show that integrase inhibitors increase the risk of TB iris. Although it was a theoretical concern, we simply do not have data to confirm that. I just want to say something briefly about drug-induced liver injury. This is common in patients with HIV and TB. In some studies, it's been up to 30% of patients. The and estimates of its are largely related to differences in case definition, and it can be associated with substantial mortality. What about increase inhibitors in patients with HIV-associated TB? Are they a risk for a liver injury? These are studies that have compared the integrase inhibitors to other regimens, and it's similar to what I showed you in the TBRS slide, and no increase in the risk of drug-induced liver injury in patients on integrase inhibitors. And this is not surprising, because if one looks at in the non-TB patients, integrase inhibitors have been associated with drug-induced liver injury, but very rare cases of significant drug-induced liver injury. Another point that I wanted to make is that patients on second-line antiretroviral therapy and traditionally on protease inhibitors, in resource-limited settings where there's not ready access to rifabutin, the strategy has been to use double-dose lopinavir/ritonavir with rifampicin, and this is poorly tolerated. Up to 40% of patients need to stop because of liver injury or gastrointestinal intolerance, and dolutegravir is a very good option to use in second-line in these double-dose lopinavir/ritonavir, provided the treatment history and resistance profile permits of dolutegravir in these patients. So to move on briefly onto drug-resistant TB, this is a problem that it affects about 500,000 people across the world annually. There's some overlap in regions where HIV is common. Drug-resistant TB has been associated with poor outcomes, less than 50% of patients achieving cure, and very high rates of mortality in HIV-positive patients with drug-resistant TB. This is starting to change because of access to new drugs for treating TB, and I've listed them here, or drugs that have been repurposed from other conditions. And some of these drugs, like Bedaquiline, have been a game changer. And this has led to dramatic changes in the WHO recommendations for treating drug-resistant TB. They've evolved substantially over the last 5 years. And we now have a short course for select patients with drug-resistant TB. There's a long course for drug-resistant TB. Neither of them contain an injectable agent, and both contain Bedaquiline. Bedaquiline, from data from South Africa, has been, and this is programmatic data, retrospective observation data showing that the inclusion of Bedaquiline in regimens for treating MDR and XDR TB has substantial reductions in mortality. So it's really been a game changer in treating TB. It has one important that complicates the use of in HIV-positive patients, and that's that there are drug interactions with antiretroviral therapy, because Bedaquiline is metabolized by CYP3A4, and therefore is a victim of certain drug interactions, particularly with efavirenz, where it's that at steady state there's a 50% reduction in exposure, and therefore efavirenz cannot be used with Bedaquiline. It can be used with nevirapine, but that's a drug that we seldom use today because of its toxicity profile. And lopinavir/ritonavir and other boosted PIs, the concentrations of Bedaquiline. And Bedaquiline, one of the side effects is QT prolongation on the E, and the concern is using with PIs might increase the risk for that. So integrase inhibitors are a really good option to use with Bedaquiline, as I say again, treatment history and resistant profile permit the use of integrase inhibitors like dolutegravir, but it's a preferable backbone to use with Bedaquiline. Finally, I just off by dealing some points about TB preventive therapy in people living with HIV. This is advised by the WHO to use to prevent TB in patients who have a negative symptom screen. If they've got none of the 4 symptoms of TB, they should, and no contraindication, they should be started on TB preventive therapy. It's been shown that 6 to 12 months of INH reduces TB incidence by 35 to 37%. People living with HIV on antiretroviral therapy, so there's benefit to preventive therapy on top of antiretroviral therapy. One of the problems with using INH is that because it's 6 months, completion rates are some. And what research has focused on in the last few years is really for shorter course options. We know that 3 to 4 months with INH is an option. 3 to 4 months of rifampicin, although we don't use that in high burden settings because of concern of rifampicin resistance. And more recently, 3 months of weekly rifapentine INHP, or just 1 month of rifapentine INH, 1 HP, has been shown to be non-inferior to longer course of INH and actually better tolerated. So moving towards the 3 HP and 1 HMs for TB preventive therapy when we can get more wider access to rifapentine. So what the issues of using dolutegravir or bictegravir with these TB therapy options? Both the drugs can be used with INH. There's no significant interaction. I've told you what you need to do with rifampicin, and so that you use the dolutegravir 50 milligrams twice daily. You have to avoid it with rifampicin. But with rifapentine and INH, the 3 HP used weekly dosing for 3 months. You can use standard dolutegravir, and I've just put a picture of a DOLPHIN. I'm going to tell you the DOLPHIN trial that gives us evidence to support that in the next slide, but you have to avoid bictegravir. 1 month rifapentine and INH, there's current data. It's being studied in the A53 trial, but currently we advise avoiding bictegravir with 1 month of rifapentine and INH until we have further data. Just to show you the data from the DOLPHIN trial, so that when combining dolutegravir with 3 HP, that's 3 months of rifapentine dosed weekly, the concern is that rifapentine, like rifampicin, reduces dolutegravir levels. But because you're giving it once a week, that might not be enough to adjust the dose. And this was addressed in the DOLPHIN trial, which is 1-2 trial, where 60 patients with this viral load on dolutegravir were given 3 8. It was well tolerated. There were no grade 3 sensitive reactions like was seen in a healthy volunteer study. And it did affect dolutegravir concentrations. There was a 26% area under the curve, 1% decrease in trough concentrations, but only modeling subsequently done using the PK data, only 1 trough value than the IC90 of, and viral suppression was maintained in all patients, 60 patients. So this supports the guidance that if you've got a patient on dolutegravir and you want to give them TB preventive therapy with 3 HP, you can give it, and you don't need to adjust the dolutegravir dose. But important, this study all the suppressed viral load on entry into this, and data on starting 3 HP simultaneously with dolutegravir antiretroviral therapy in patients who are viremic. So starting at a regimen, we don't have data to support using 3 HP immediately until they are viral suppressed, and then you can use the 3 HP based on this data. So my final summary slide is just highlighting the major points that I've made in treatment. Dolutegravir, the dolutegravir dose that's currently advised is 50 milligrams twice daily. Raltegravir is 800 milligrams twice daily, and you need to continue with those doses until 2 weeks after TB treatment is completed. The other integrase inhibitors should be avoided, rifampicin, because of drug interaction. The incidence of TB-RS is not increased in HIV-TB patients in randomized controlled trials to date, but need further data in patients with CD4 counts of less than 50. Dolutegravir is well tolerated in HIV-TB patients without an increased risk of drug-induced liver injury. There are no interactions in the integrase and Bedaquiline predicted, and dolutegravir can be used together with 3 HP at standards, provided the patient has a suppressed viral load. Finally, just to acknowledge the funding of my research program in Cape Town. Thank you very much for your attention.